Delighted to be here and really the warm-up act for the main event, which is 3 sets of NHS Digital colleagues presenting their really exciting work around various aspects precipitated by COVID. I'll just say a few words about NHS Digital itself. I can see that we've got quite a few NHS Digital staff who've joined, which is fantastic, alongside some familiar names and some not so familiar names. So really good to have you all here. So NHS Digital, we're the data and technology provider for the partner for the NHS. So we work with a lot of the other national bodies. We provide an enormous amount of IT infrastructure, particularly over the COVID period. We've provided the NHS app, which is where all of you who are going on holiday can download the COVID information and vaccination information in order to facilitate that. We've provided the IT infrastructure to support the vaccination programme, aspects of the testing programme. We provide big areas of technology like NHS email, the Spine, which is a place where all hospitals, GP practices, providers of different types of NHS care can trace patients and get the patient details populated. And then we also do an awful lot on the data side, which is particularly close to my heart in data services. So we collect and capture really big sets of data from mental health services, secondary care services, community services, prescribing, various audits, huge amount of workforce data as well. And we use those data to do several things. One is with appropriate legal bases, we link some of the sets together and then make them available for external customers, usually with the identifiers taken off, where they have an appropriate legal basis to do this. And this enables a great deal of research to take place across health and care, and is the backbone of lots and lots of research. And some of the new treatments that were identified over the COVID period that help massively with the treatment of COVID were identified with the help of our data. So that's a really important feature of what we do. We also process the data, do a lot of data quality work, feed that back to local organisations, and we also do a lot of analysis and produce a lot of open data sets and statistical publications, just under 300 statistical publications a year. So these 3 presentations you're going to hear this afternoon are all around various aspects of COVID, but perhaps more importantly, they're all examples where COVID precipitated us doing things slightly differently, whether that be in the first one around a survey that was periodic, increasing the frequency and happening very quickly to get some real insight around children's mental health and the potential impact of COVID restrictions around that. The second one, which is using our data sets and our analytical skills in partnership with others to support citizens' direct care and impact on people's lives that way. And the third one around a new GP data set specific to COVID and some of the analysis and insights we drew from that, which also then also enables other users of the data to understand some of the key features. So without any further ado, I'm conscious slightly ahead of schedule, but I'll hand over to Sharon if she's ready to kick off the first session around the mental health survey and the results from that.
Yeah, thanks, Chris. Hi everyone, I'm Sharon Thandi, so I'm the Analytical section head in the Population Health, Clinical Audit and Specialist Care team. So yeah, I'm going to talk to you a bit about the work we've been doing on the mental health of children and young people survey in 2020. So this was a follow-up to the main survey that we did in 2017. Okay, so the children's mental health surveys, which form official statistics, are carried out on an ad hoc basis with previous surveys conducted in 1999 and 2004. The last main survey was done after a long time in 2017, and then for the first time involved a follow-up survey in 2020 using the same cohort of children and young people as 2017. This was a unique opportunity to examine the mental health of children and young people in England before and during the pandemic. As well as assessing changes in children's mental health over the pandemic, it was felt that the follow-up survey could fill a gap in assessing how children have generally been affected by the pandemic. So there's been a lot more focus on this recent cohort of respondents than carried out in previous main surveys. So the 2020 report addresses two key aims. Firstly, it compares the mental health of children and young people in 2017 and 2020 using a consistent measure of mental health disorder based on the Strengths and Difficulties Questionnaire, which is commonly abbreviated to SDQ. So you'll see SDQ on the slides that follow. And secondly, it describes the life of children and young people during the COVID-19 pandemic. So it looks at the circumstances and experience of children and young people in July 2020 and the preceding months. And we look at sort of family life, education, services, and just sort of worries and general anxieties about the pandemic. So findings in the report are presented by gender and age bands of 5 to 10-year-olds and 11 to 16-year-olds for all the analyses and comparisons between 2017 and 2020. 17 to 22-year-olds are presented for 2020 findings. There's no comparisons with 2017 as we only had 17 to 19-year-olds in the sample at the time. The survey is designed to be representative of all children and young people, so not just those who took part in the survey. So findings are weighted and calibrated to population totals. As with any other survey, the findings are not actual rates, but estimates subject to a margin of error. These are presented in the form of a 95% confidence interval, which show that if we were to repeat the survey again and again, we'd get the same estimates within a certain range 95% of the time. Further details on any of the statistical aspects of the report can be found in the survey methods of the publication. And I can send you a link to that afterwards. Sorry, I've got a bit of a dry throat today, typical. I'll sip on my water. My slide's not moving along. Okay, so before I go into sort of any further detail, I just wanted to touch on the sort of collaborative working that we did on this survey. So the survey was funded by the Department of Health and Social Care, and then the survey content was developed with a wide range of stakeholders to ensure the most relevant topics were prioritised for inclusion. This included a steering group comprising members across government, so we had PHE on there, NHS England and the Children's Commissioner, and then the consortium and the third sector as well. So the consortium involved working with ONS, NatSen and academics in children's mental health. And they were sort of contracted by NHS Digital to develop and test the survey and oversee the whole data collection process, reporting into the NHS Digital surveys team. The analysis and report was produced jointly between NHS Digital's publications team, which is where I sit, and the consortium, with myself leading as the responsible statistician, quality assuring and signing off all the outputs. So even though the methodology for both surveys was pretty much the same, there were some differences which I'll just touch on in this slide. So in 2017, the survey was done face-to-face, and then we had to move to an online survey in 2020 because of the pandemic. The 2017 survey was done with 2 to 19-year-olds. And then in 2020, because we followed the same cohort of children and young people, they were then aged 5 to 22 years old. In 2017, data was collected between January and September 2017, with results published in 2018. For 2020, we collected data in July 2020. And then we published the report in October 2020 last year. For 2017, we collected data from children, young people, parents and teachers. Whereas in 2020, because of the pandemic again, we just collected information from children, young people and parents. So in 2017, we achieved a sample size of just over 9,000 children and young people. But then in 2020, because we had to get consent for follow-up, we had a reduced sample size of just over 3,500 children and young people. Sorry, I've skipped. Hello. So the response rate in 2017 was 52%, and the response rate in 2020 was 45%. So this was still really good for an online survey. In 2017, we used a detailed and complex development and wellbeing assessment diagnostic tool, also known as DARBA, but also we looked at a strengths and difficulties questionnaire to measure mental health disorders. In 2020, due to the move to an online survey, only the SDQ was deemed appropriate to use in this mode. And then just to mention that the survey is based on a stratified multi-stage random sample of children and young people, which is drawn from the NHS patient register, which is held by NHS Digital. This means the sample selection takes account of certain demographics in the sample, such as gender, to ensure results are representative. Okay, so just to give you a bit of an explanation into how we measured sort of mental health disorders in children and young people. So both the 2017 survey and this 2020 follow-up survey use the SDQ to assess different aspects of mental health, including problems with emotions, behaviour, relationships, hyperactivity and concentration. So responses from parents, children and young people were used to generate scores from the questionnaire to estimate the likelihood that a child might have a mental disorder. So this was then classified as either unlikely, possible or probably have a mental health disorder. So the report focuses on comparisons between those that have a probable disorder with those that are unlikely to have a disorder, as we can't be sure about those who have a possible disorder, so they can even fall into the unlikely or the probable category. Okay, so I'll just touch on some of the key findings we found on the prevalence of mental health disorders in the 2020 report. So one of our key findings was that 1 in 6 children aged 5 to 16 years old were identified as having a probable mental health disorder in 2020. So to put this into context, that's 5 children in a class of 30 children. This has increased significantly since 2017, where 1 in 9 children were identified as having a probable mental health disorder. The increase in probable mental disorders was evident in both boys and girls aged 5 to 16 years old. So in boys, the rate increased from 11.4% in 2017 to 16.7% in 2020. Sorry, it's my throat again. In girls, it increased from 10.3% in 2017 to 15.2% in 2020. And then when we looked at primary school children and secondary school children, we found sort of similar patterns here as well. So among children of primary school age, 14.4% had a probable mental health disorder in 2020, which was an increase from 9.4% in 2017. Among secondary school children aged 11 to 16 years old, we found that 17.6 were identified with a probable mental health disorder in 2020, which is an increase from 12.6% in 2017. So when we looked at the older age group, so among 17 to 22-year-olds, we found 1 in 5 were identified with a probable mental health disorder in 2020. About 1 in 4 young women were identified with a probable mental health disorder, as opposed to 1 in 8 young men. Comparison with 2017 is not possible due to the different age groups covered in the surveys, as mentioned earlier. Okay, so we looked at ethnic breakdowns as well. So for 5 to 16-year-olds, we found that 18.8% of children of white ethnicity had a probable mental health disorder in 2020, which compares with 7.5% of children from a BME background. Rates of probable mental disorder increased for children of white ethnic backgrounds since 2017 from 13.1%. So although rates appeared to also increase for children of BME backgrounds, this particular increase was not statistically significant. So with the pandemic, many families have spent more time together in close proximity at home. So for some families, this may have been a positive thing, and for some, not necessarily so. So we asked parents of 5 to 16-year-olds a set of questions to see if there were any problems with family functioning. So this included positive statements such as we confide in one another, we feel accepted for what we are, and then negative statements such as there's lots of bad feelings in the family, or we avoid discussing our fears and concerns. So in 2020, children with a probable mental disorder were more likely to be living in a family who reported problems with family functioning at 28.3%, compared to children who were unlikely to have a mental disorder, where it was 11.7%. Okay, so the last slide in this section, we looked at parent and guardians who took part in the survey. We asked them a set of questions about their own mental health using a psychological screening questionnaire. So questions in that questionnaire included things like, have you recently lost much sleep over worry? Have you recently been feeling unhappy or depressed? So those kinds of questions. This helped us to understand parents who may be in psychological distress. So in 2020, we found that 30.2% of 5 to 16-year-olds with a responding parent had experienced psychological distress, had a probable mental health disorder. This compared with 9.3% of children whose parents showed no distress in 2020. And you can see that in the chart there. So I've just covered all the key findings in relation to children's mental health. So I'll now touch on some of the key findings in terms of the new questions we asked around life during the sort of pandemic. So one of the questions that we asked in the survey is whether lockdown had made lives worse. So our survey found that 2 in 5 children and young people who were aged 11 to 22 felt that lockdown had made their life either little or much worse. When looking at this by disorder in the chart, you can see that those children and young people who were identified as having a probable mental disorder were more likely to have felt that lockdown had made their life worse than those who were unlikely to have a disorder. For example, of 17 to 22-year-olds, 59% of those with a probable disorder felt that lockdown had made their life worse in comparison to 37.3% of those without a disorder. We asked parents of 5 to 16-year-olds how they thought their child was feeling in regards to COVID-19. Sorry, my throat again. We found that the biggest anxieties that parents found the child were having were about missing school or work, and also about family and friends catching COVID-19, with over 1/3 of children having a parent who thought these things. We also found that 22.3% of children had a parent who thought that they were worried about catching COVID themselves. So at the time of answering the survey, 11 to 22-year-olds were asked how often they felt lonely. We found that 1 in 10 children and young people reported always or often feeling lonely. When you look at this by disorder, as can be seen in the chart, we can see that children with a probable disorder were more likely to report feeling lonely compared to those unlikely to have a mental disorder. And then when you break it down by gender, we can see a similar pattern. Sleep problems. So parents of 5 to 10-year-olds and children and young people aged 11 to 22 were asked if they had problems with sleeping in the past 7 days. A survey found that 28.5% of all 5 to 22-year-olds reported having a sleep problem. When you look at this by disorder, we can see that the 5 to 22-year-olds with a probable mental disorder were more likely than those without a disorder to have a sleep problem. This seems to increase with age, we found. So as we can see, there's 50.5% of 11 to 16-year-olds with a disorder that had sleep problems, but then this increases to 69.6% of 17 to 22-year-olds with a disorder having sleep problems. We looked at what resources children had available to them during the pandemic. So parents of children aged 5 to 16-year-olds were asked if their child had adequate access to a range of resources or support at home during the April to July period in 2020, when lots of schools were predominantly closed. This chart highlights that children with a disorder were less likely to have access to all types of resources and support than those children without a disorder. This was things like having reliable internet access, having a laptop or tablet to work on, and having a quiet space to work in. We found that 76.4% of children without a disorder received regular support from their school or college, and this compares to 62.6% of children with a disorder who had this regular support. So that's a lot of the sort of key findings that we found from the survey. I'll just sort of finish on some of the sort of strengths and limitations of the survey now. So one of the strengths that I've kind of already touched on was that the survey is based on a robust random sample of children and young people. So for the 2020 report, both the 2017 and 2020 estimates were based on the same sample of just over 3,500 children and young people. This was to allow like-for-like comparisons before and during the pandemic. In terms of measuring mental health disorders, the SDQ was used in 2020 to measure mental health. Information was used to derive this measure, was also used in 2017, therefore providing a consistent measure of mental health disorders in the population. Although the 2017 survey used the Dorber measure as well, as alluded to in the previous slide, the SDQ was also included, so we could make those comparisons between 2017 and 2020. Other robust measures of well-being, family functioning and parental psychological distress were included in both surveys. And then the pandemic anxiety scale was also used in 2020 to measure the pandemic-related anxieties described earlier. This is commonly used in others. This has been commonly used in other research. As I mentioned at the start as well, because the content was developed with a wide range of stakeholders, this ensured sort of most relevant topics were prioritised for inclusion, and we brought in the relevant experts on children's mental health. We produced timely data, so results from this study were published within 3 months of completing data collection. This is the quickest we've turned around sort of estimates from a survey before. So moving on to some of the limitations. So due to the pandemic, we had to change the mode of the survey from being face-to-face to online. These differences may have introduced some modal effects in responses. So while it's not possible to quantify the effects of this, we do advise that caution should be taken when comparing both estimates. Non-response was higher among children and young people who were at greater risk of mental health disorders. So non-response was accounted for in the weighting. However, as a result, the 2020 estimates may still be an underrepresentation of rates in the population. Having said this, a response rate of 45% is higher than what most other online surveys have achieved. In terms of comparability, as the SDQ measure was used for the 2020 report, direct comparisons should not be made with estimates in the 2017 report where we used DARBA. Research indicates that the SDQ measure is likely to underestimate the prevalence of mental health disorders. However, the cross-sectional analysis being done in the 2020 report calculates an equivalent measure of mental health for children in 2017 using the SDQ, so it's all consistent. So as such, comparisons should be made using the 2017 and 2020 estimates presented in the 2020 report. In terms of change, it's difficult to quantify how much change is down to the pandemic. Analyses are cross-sectional and no conclusions about causality can be drawn from any of the associations presented here. So to conclude, this survey series is adding to a robust evidence base to help deliver the commitments on children's mental health services in the NHS long-term plan. We are currently finalising the findings from the 2021 survey with results to be published next week, so please look out for those. And we've also now funding agreed for a repeat survey in 2022 next year. Thanks for listening. I'll take any questions now.
Thanks very much, Sharon. On echo, sorry. Yeah, thanks very much, Sharon. Yeah, really interesting presentation. I'm sort of looking at the timing. We've got a range of interesting questions from Susanna Kieran. If I can, I want to try and sum those up. I think there's a general question of, obviously what you've done here is collect survey data and analyse it and present the data. I'm wondering how much in general you sort of looked into the sort of questions that Susanna's raising here about looking at what's behind the data. Are there differences in the way that boys and girls answer the questionnaire, for example? Are there inherent differences for children with special educational needs, or differences by ethnic category? And I know that the timetables for these sort of things tend to be very tight. So how much capacity did you have to sort of dig below the numbers a little bit more, in the way that very, very interested people might have done?
Yeah, so I think when we were doing the analysis, we kind of looked at all the demographic breakdowns. So the findings in the report, they kind of show, the differences between gender, the ethnic differences, but, I think further work is needed to sort of identify why we've got these kind of patterns. So I think one of the things that we tried to do in the Wave 2 follow-up report that's going to be coming out next year, we tried to drill down into the ethnic differences a bit more, because that's one of the things that the Department of Health and Social Care really wanted us to look at, is to try and understand why we've got these differences in ethnic group. But obviously, because the results are not going to be out until next week, I can't say anything about those just yet. But we have started to drill down into those kinds of things.
Thank you, Sharon. And just one sort of combination of a question I had in mind and Roger Mulvey's comment, which is that we tend to think of mental health as an illness that you acquire, and it's a negative. And to some extent, I guess this survey is trying to pick up whether people have acquired that negative. But presumably, the survey wouldn't directly capture if people were in good mental health and actually felt that they were much happier as a result of lockdown and COVID restrictions. The survey just doesn't capture that.
Yeah,
It's a separate thing.
Yeah, so so that was one of the things that we recognised that we'd done when we presented the findings last year. So what we've done for next week's result is we've kind of looked at the positive impacts that the pandemic might have had as well. So we've looked at and reported on those that have said that lockdown has actually improved their quality of life. So we have looked at that for next week. So yeah, look out for that.
Great, thanks, Sharon. I'm aware we've probably got more questions than we've got time for in this gap. We'll try and pick up some more questions at the end. Just one more, so picking up Andy Sutherland's question. Do you have a sense of, the results are quite startling? There is some quite strong results there. How much of an impact do you think they've had on government policy?
I think it's had quite a good impact, because obviously, we used some of the findings for the Department of Health spending review bid, and it's kind of helped to sort of secure future funding for this. So I do feel like it's filling a bit of a gap in terms of, analysis on children's mental health.
Absolutely, yeah, thanks, Sharon.
Sorry, just to add on that specific thing, a copy of the report also went to SAGE, so when they were considering or advising around lockdown policy, that was considered, but obviously it has to be balanced against a whole range of other factors, but it was thrown into the mix, so very important from that perspective.
Absolutely. Well, it has the ring of familiarity in terms of some of the things we've heard at term press briefings and so on. So I think it has an impact. But I think I'm going to pick up one more question. Actually, there's a couple of questions about the links between mental health and LGBTQIA+ and sexual orientation issues. Is there anything particular in this survey that addresses those questions?
Not at the moment. It's not something that was picked up by the sort of stakeholders when we were in sort of consultation about the questions and things. And even when we do the findings for next week, it's not something we've looked at. But as I mentioned, we are looking at doing a 2022 survey. So if it is of interest and it's something that's needed, then we can definitely look to sort of include that.
Great, thanks, Sharon. And you've raised loads and loads of questions. Brilliant presentation. With apologies to colleagues, I think we'll sort of park that at that point, and maybe there'll be a bit more time for other questions at the end. And I think at this point we'll hand over to back to Chris or to Kieran.
Thank you very much for having us. My name is Kieran Baker. I'm a head of delivery in the Data Services Director at NHS Digital, and I'm joined by my colleague Lucy. Do you want to jump in, Lucy, and introduce yourself?
Hello, yeah, Lucy Ellis-Brookes, Associate Director for Data Curation. Hello.
Thank you. So you're going to get a bit of a 2-for-1, I guess, with us. In the first part of the presentation, I'll be taking you through a whistle-stop tour of the inception of the shielded patient list and the challenges and the travails and the benefits of identifying the most vulnerable in our society at the early part of the pandemic. And then the second half, Lucy will show you how that work evolved and how we moved into use more extensive and more robust identification methodologies for identifying the most vulnerable in our society. And again, we'll touch upon the challenges and the benefits of that. So I think there'll be less statistics, but more about the process of how we've used our data, wrangled the data to create a really good benefit, but also suffered from the challenges and had to deal with those challenges along the way. So first of all then, I'll talk about the shielded patient list. So cast your minds back to March 2020, very early stages of the pandemic, and the Prime Minister made a bit of a commitment to try and ensure that anyone in our society who suffered from serious health complications and who were considered to be extremely vulnerable and therefore had a high risk of severe complications or even mortality from COVID-19 had to shield themselves from social contact. Now, the important bit about this is that we, of course, needed to identify who those people were in order for us to be able to provide them with the appropriate guidance. And this kicked off quite a rapid cross-government response, including us at NHS Digital, colleagues at NHS England, Department of Health and Social Care, NHSX, Cabinet Office, and so on. It was a really big effort to try and produce and identify these patients at relatively quick order, given the progression of the pandemic at that time. So the first thing is, how did we do that? So it all starts with the clinical definition. So the Chief Medical Officer for England provided clinicians at NHS Digital and NHS England with a list of conditions that based on the research and understanding of the progression of the disease at that time, that they felt that anybody with those conditions would have severe complications, as I've mentioned. So those high-level definitions that you see there on the left had to be then translated and converted into a technical methodology. So this meant liaising with clinicians, with terminologists, to convert those high-level descriptions into specific concept codes, such that we could profile the data that we held to identify patients with those specific conditions. But also we then had to actually convert that into a technical rule set and coding set that we could run across all of our entire data sets, such that we would generate a list of patients at the end. And I don't want to put too much splendor on this. I'm not going to sit here and say it was a massive algorithm. In the very early days of the shielded patient list, it was a simple if statement. It was if this, then they're on the list. So using those clinical, the clinical guidance and the clinical feedback, would convert that into a technical methodology and produce that shielded patient list. I put final there on the right hand side in inverted commas, because at the time we thought, wow, we've created this list of circa 900,000 people. And at the time of the first version, it was using hospital data and primary care dispensed medications. But of course, 18 months later, the shielded patient list is still operating, and it's grown to include more data. So in the weeks following the first list, we started to include GP data extracted directly from the GP systems. We built mechanisms at very quick order for GPs to add patients and deduct patients from the shielded patient list. And equally, we allowed consultants in hospital trusts to add and deduct patients from the shielded patient list to ensure we had that clinical oversight and clinical review of the list, and that it wasn't a nationally curated list in its entirety. And all of that required bespoke data flows, bespoke linkages, and building a platform and a service to satisfy all this, and a variety of quite complicated logic to determine how a person is added and removed from the list. So, you know, if a consultant was to add a patient on the exact same week that a GP was to try to deduct a patient, well, who wins? So we had to work with clinical leads to try and understand that logic. But then you also have to think that we've created this list. What do we do with it then? So the important point to ensure that people got the guidance that they needed, it was to disseminate that list appropriately relative to our approvals and IG clearance to the appropriate endpoints, so that patients could get letters and text messages to give them the all-important guidance that they needed. Send information out to people at the Cabinet Office so they could support the clinically extremely vulnerable persons service, and so on. So as you can imagine, it was quite a complex piece of work, a fantastic effort across multiple organisations that was stood up in literally a little over a week. So there were some very long nights and early mornings at that particular time. So what were the challenges then, other than the ones that I've already touched upon. So specifically focusing more upon on the data themselves. So some of the data sets that we utilised were largely considered to be used for payment and for commissioning purposes, which meant that we were reliant upon the coding of diagnoses and procedures within that data and hoping that it was accurate. We did come across instances where patients had diagnosis dates on the date of their birth, which could be seen as logical, but that affected the identification and the rubric because the methodology as part of the shielded patient list had time limits on some of the conditions. So if a patient had a specific condition in the last 2 years, for example, of course they would be missed out if the person coding that onto our record added it to their birthday. So we started to pick up little things like this. Equally, we saw codes come in which identified people, but then the following week, when the data flows were refreshed, the codes had disappeared. So was that a clinician's attempt to deduct someone from the SPL, or was it just cleanup of someone's system? So we had to be quite cognizant of all these little intricacies and work through them a step at a time to try and understand and identify the best way forward of handling them. There was overall incorrect coding. So for example, there was quite a lot of patients that had sickle cell disease on their record, when in fact actually what the clinicians meant was sickle cell traits, but that of course resulted in at the point of production of the shielded patient list and subsequent iterations after, a lot of patients being added to the list. Incorrect coding of Down syndrome, so where a patient had had a Down syndrome test on an unborn fetus, then the Down syndrome is actually added and coded to the mother's record, which again resulted in misidentification of people in addition to the shielded patient list. Lots of other things that happened that we had to work through: demographics information, correct contact details. There's a concept of formally versus informally deceased, and informally deceased is where a patient is flagged initially, but it's not been fully signed off by a coroner. So that produced some complications as well. Correct NHS numbers being flown as part of secondary users data as well. So we had to implement additional methodologies and routines in order to try and ensure that the accuracy of the data that we had was spot on, so that we were confident that what we were producing as part of the shielded patient list. And equally, it's really important that it was dead right, because ultimately patients were at risk, and therefore we need to make sure we identified the correct people. And I think the important point to note is that this piece of work shone quite a lot of light on data quality issues in the data that we routinely collect, and we had to iteratively improve our processes in order to improve the accuracy of the list. And comms was really important in that. So ensuring we had open communication with the public, with clinicians, to make sure that any concerns were raised, we could investigate them and implement any remedial action thereafter. So the production of the initial list kicked off a whole variety of other activities in order to ensure that we were adding the correct people to this list and that the correct people were getting the guidance that they needed. So what were the benefits and some of the other outcomes? Well, ultimately, right at the top there, the most vulnerable in our society were able to protect themselves from COVID by getting the appropriate guidance after being added to the shielded patient list. But there were a whole raft and a variety of other benefits outside of shielding. So social support and food parcels, which I'm sure you heard about. Patients that were identified as clinically extremely vulnerable and added to the shielded patient list got free medicines deliveries. They were ultimately prioritised for vaccination earlier on this year. They got access to mental health support and so on and so forth. So there's quite a lot of benefits came out of a production of a list in the dark nights of March 2020 that subsequently iterated across the months. And I think we're on SPL version 74 also now. So it's been going for quite a long time, and as I said, slowly evolving. So given that it's been evolving, I think it's really important to note that we had to support the evolution and the development of the shielded patient list through the provision of public and private facing dashboards to allow the public, government departments, regional organisations and so on to better understand the composition of the CEV list, to track the growth of the list, to identify any unexpected variations and further data quality issues, and also to support local and regional planning around the provision of services to the clinically extremely vulnerable. So we produce quite a lot of dashboards, some of which are available publicly, some of which are currently only available privately, but we're hoping to take more of those public in the coming weeks. And then I think this is the last one from me. One of the key questions that we got posed with in the early days of the shielded patient list, as we were progressing through that first lockdown, was how effective is shielding been? So we at NHS Digital were commissioned by Department of Health and Social Care to work in collaboration with the Deputy Chief Medical Officer for England to try and evaluate whether or not we could answer that question quickly. Again, this was in the height of the pandemic, and therefore there was a rapid turnaround requirement on this one. We produced quite a lot of really nice and neat analysis, which is published, and the link to this is in the end of this deck that I'm sure we can share. And we identified some quite interesting trends, but sadly, we found it difficult to untangle clearly the effect of the shielding intervention because there were lots of confounding factors that contributed to the changes in hospitalisation, mortality, and COVID-19 test rate. So, for example, shielding patient wasn't the only intervention. There were other interventions imparted at the same time, which could have affected results. Did people even follow the guidance? And this is the subject of a piece of work that's been undertaken by the ONS, who are surveying patients who are suggested to shield to better understand their shielding behaviour. It was also difficult, given the unprecedented nature of this pandemic, to pin down a true comparator population against which to compare the outcomes of patients on the shielded patient list. I think that the closest analogy that we had was that the flu. The bad winter of a couple of years ago where flu was quite rife, but still it's not a particularly identical situation to the one that we're currently experienced. And equally, progressing from winter through into spring and then into summer, seasonality of course also plays a part. But as I said, it was still an extremely good piece of work, and we tracked the health outcomes of the patients on that initial version of the shielded patient list throughout the summer and into autumn last year, and those data are available online. So that's it from me. I'll hand over to Lucy.
Thanks, Kieran. I'll try and speed up a bit because I think we're running a bit behind now. So I'll do my next slide, please, and you can take me through this. Right, so I'm talking about the population risk assessment work that we did. So to give some background, this was some research was commissioned by the CMO, back in the summer to better understand the risks of COVID and associated with outcomes of COVID. Oxford University developed a Q-COVID tool, which is based on similar risk stratification work they've done for other conditions using their Q research database, linking multiple sources, and they published this paper, which the links are all at the end of the presentation. And then the DH then commissioned us to apply that model to the population. But Q-COVID and other Q tools are often deployed directly into GP surgeries, but the CMA wanted this to be essentially done across the population. So the Oxford partners developed a calculation engine, which we refer to as a black box, which would take the algorithm and spit out risk scores for us. But our challenge was to build a platform to host that, assess the feasibility of using our data sources, which were different, and whether we could safely generate risk scores to be used for what purpose. So that was the context that we were working in. Next slide, please, Kieran. Firstly, just what is Q-COVID, briefly. So it's a research with multiple partners, and it looks at the risk factors for the hospitalisation and death related to COVID, and it's based on the pandemic first wave. So there are limitations to it, but it's massively powerful. It was one of the first publications we were involved with that really broke down what the risk factors were and went into medical conditions in more detail than the SPL previously had. So there were demographic features and medical conditions that were found to be different risks. And what it does, it takes these risk factors, about 45 or so, 50, it weights them. It's not a binary thing. It works looking at combinations of risk factors, and it calculates estimates for absolute and relative risk of being hospitalised or dying from COVID. There's a tool that Oxford also produced, which is on the right here, a screenshot, and you can look at that to see what the various risk factors are, although there's a big caveat on that saying not to be used for clinical assessments. But again, the link's at the end. So next slide, thanks. How do we approach this? Well, the big thing we had to deal with first was information governance. So whilst the CMO and DH asked us in the summer of last year to look at this, actually the formal commission wasn't until January in the midst of vaccination programme, because that's what we actually use the data for in the end. So without a formal commission and no clear use case, we were unable to use identifiable data. There's absolutely no way that we could process 60 million people's records without their consent or awareness for no clear discernible purpose. There's an issue about profiling and many IG concerns. We didn't know what the data quality was like and whether the results would be valid. We were working with a black box, so we didn't know what was going in and coming out at the start. And if we didn't know what the scores would be used for, it could be risk assess someone, say they're high risk, and then do nothing about that. So all these things meant that we had to really approach this very carefully. We were able to use samples of depersonalized data in stages as we developed through the proof of concept. We minimised the data so that we weren't processing children's data, we weren't processing people with no conditions, we weren't processing data which couldn't possibly end up in a high risk score. So there was approaches we took that it made it quite hard in some respects. As I'll touch on in a bit, the calculation engine requires postcode to derive deprivation. We couldn't use postcode, that's identifiable. So the results we were getting out with the dummy data or with the depersonalized data were not necessarily accurate or didn't reflect the final results. So we really had to guess about what the final numbers would be. So it's a big challenge, and we used dummy data where we could, but rightly so. And we met these hurdles all the way through. But yeah, that was a challenge that we have to deal with. Next slide, please, Kieran. So what data sources did we use? That's the GP data that Kieran's referred to, hospital data from secondary care, and the actual shielded patient list itself. All these were used under the COVID public health directions, which gave us permission to use the data directly for these purposes. Next slide, and there's more information about these data sets on the website. So what are some of the challenges? Well, actually, Kieran's challenges with the SPL are exactly what we had as well, using similar data for something quite similar. Initially, we had to translate the parameters that Oxford had used into something that could be applied with our data. So the QCOVID tool was initially developed using read codes. Our data is coded in SNOMED, so we had clinical terminologists working on with us to translate those codes from one set to another. When they didn't always map at all. In fact, they didn't map well. So that's a challenge. The GP data we had access to doesn't have all conditions in. So whilst it covers the whole population, not all conditions are currently extracted. So we knew we would have holes, and we needed to plug those gaps with other data sources or quantify what those gaps might be. How do you quantify the unknown? We had to apply defaults. I'll talk about that on the next slide in more detail. And when we were testing with depersonalized data, the results were never going to be exactly the same. So that kind of was challenging for data quality, but also we couldn't then link back and look at the records, see whether they were different. We weren't allowed to look at the patient record. So a lot of the testing that we had to do was done right at the end when we actually were allowed to use identifiable data, which was a challenge. And again, Kieran's talked about the data changing and conflicting. So ethnic category is recorded in GP data and hospital data, and it isn't always the same, and it does change over time. So we have to come up with rules as to which one we would use, and those hierarchies were a challenge as well. Next slide, please. I mentioned default values. So the calculation engine required mandatory data on demographics to enable it to work, and if those were missing, it would substitute a default. And so these were baked in. And you can see here the defaults for BMI, ethnicity, sex, and Townsend score, which is used for deprivation. We had to decide whether to accept these defaults because we did have a lot of missing data initially for BMI and ethnic category in particular. So do we accept these or not? And what's the risk of accepting these? We did a lot of scenario modelling with dummy data to understand how many people we would miss out, but it really depended on the use case and what we were going to do with the data, whether we would overestimate risk or underestimate risk. The use case, which I'll get on to next, ended up being about prioritising people for vaccination. And so we decided we would overestimate the risk scores by using higher risk defaults so as to be more inclusive and have more people included in the pool of people who'd be prioritised for a vaccine. Hence, we went with, we kept sex being male and Townsend score being 0, which is the average deprivation score, and we went with the highest risk or high risk of, for BMI and the highest risk for ethnic category. And that was debated amongst clinicians for a very long time. Next one, please, Kieran. So I said you usually put the use case at the start, but we got the use case in January, and we had then a couple of weeks to actually to spit out the answers. But which is right, because the use case did change actually over the course of that time. So January was when the vaccination program was being rolled out. So JCVI had defined their categories, and the use case was really to identify people who are at highest risk of dying from COVID and add them to the SPL so that they could be prioritised for COVID vaccination in, I think, group 5. I can't remember which one it was exactly, but after the over 70s. So we were prioritising people. So everyone would eventually be offered a vaccine. So that covered some of the IG risks, but it was prioritising people who hadn't been offered already. There were thresholds that were agreed by the HCMOs. So someone was high risk if they had their absolute risk was greater than or equal to 0.5%, or the relative risk was greater than or equal to 10. And again, those thresholds were debated, but that was thought to represent the top 2% of the vulnerable population. We generated flags which were added to the SPL, showing that this flag had come from Q-COVID or from the population risk assessment, not from the algorithms that Kieran's described. And also, importantly, indicating whether defaults are being used. So the GPs would know whether this risk score had been calculated with data, true data, or with missing data defaulted, because we had to be really clear to patients about how their data had been used. And equally, we also provided information to GPs on who had been processed, and even if they hadn't been deemed as high risk, so that again GPs would know whether someone was just below threshold or further down. Next one, please, Kieran. I'm getting there. So just a couple of slides on the results, which I'm not going to talk through in detail. But the outcome was that we looked at 43 million adults, so we didn't look at people ordering the SPL, we didn't look at children, and we identified 17 million who we would process through the black box, who could be high risk based on what we knew about them. 1.5 million people were identified as high risk by the population risk assessment, and we have a breakdown there of the age and sex distribution. Just a couple of comments on that on the next slide. You'll see the left-hand chart is the age sex distribution for the people we processed, whose data we processed, and the right-hand side is the cohort identified as high risk. It's a strange bimodal cohort. Part of that dip is because of people on the SPL who we removed before processing. So they would have, if we processed those people's data, they would have been high risk. But also that was because of the differences in absolute and relative risk. So if you look at the next slide, the chart on the left shows if you were to look at the absolute risk scores only, you show a really clear distribution of high risk people who are in the older age ranges, dark blue being males, so more men. But if you look on the right hand side and you look at relative risk only, actually the age distribution is completely different. So add those two together and you get that strange pattern that initially confused us, but that makes sense. And then I think finally, I'm almost there. Yes, so we passed the data onto the SPL team. People were added to the SPL on 2 tranches, under 70s 1 week, over 70s a week after. The numbers here on the headlines were different because we were being pressed to give a number of how many people we were adding, and we hadn't finished the work, so we had to kind of guesstimate. So all the newspaper reports say 1.7 million, when actually it was 1.5 million. There's a bit of coverage, and then we had to do a lot of work explaining some coding differences, explaining the defaults, explaining why certain conditions were overrepresented. But that was all done afterwards, and generally it was really well received. Final slide, next, or penultimate. It was not just a few of us, it was a massive cross-team effort, both within NHS Digital and across NHS Digital, and across the health spectrum, and some people on this call were involved. And we won an award this year from the RSS for excellence in healthcare data analytics. The next slide has got some links on, and I assume you'll get that slide pack. Thank you for listening, and sorry that we've managed to overrun.
Well, thanks very much, Lucy and Kieran. So I think my reflection is that the shielded patient list was a massively influential piece of work and an enormous piece of work in a very short period of time. And congratulations on the award, which I think is very well deserved. I just had one general question, which I think is similar to the question that Kieran's posted in the comments, which is, as statisticians, we're sort of familiar with the concept of exploiting data to derive a number. To say 95% of people think this, or 27% of people think that. And my impression is that the shielded patient list was used fairly extensively to make decisions that affected individuals. So either at the mildest level, sort of sending correspondence in the post. And I wondered if you were cited on how much pushback there was from individuals, either from people who were on the list and thought they shouldn't be, or from people who weren't on the list and thought they should be, and how that sort of factored into the work that you did.
I think we could both talk about this for hours, with Kieran from a wider SPL perspective and me from the risk stratification side. That we had pushback. A small number of people were concerned about the use of defaults. We had some really good comms and guidance, and we pushed that out through the GPs and through some of our wider groups, so that people were very clear about how and why they've been added, and also they could follow up, that they could get removed if they wanted to. So we've tried to be really transparent about it. As you said, there's a lot of people to deal with, so we couldn't contact people individually, but we tried to work through groups. And where we found that there were common issues, some of which Kieran mentioned, we had an issue about gestational diabetes. We would then work with groups who knew the area, and we'd issue some guidance and support to really further explain that. So yeah, some people wanted to come off, but Kieran, anything to add to that one?
Yeah, so I think that was the quite important part of the SPL initially, was to identify that mechanism where people could go to their GP or to their clinician and say, I don't want to be on the list. I don't care what you say about my record or my condition. I don't want to be on, just take me off. And, and the GPs therefore had that opportunity to do so. And where someone contacted us to our SPL query mailbox and said, I don't think your records are right, I shouldn't be on this list, the recommendation would be, well, we've investigated your record. This is what it's telling us. If you're not satisfied, you need to speak to your GP, and then they have a mechanism to remove. So I think looking at the dashboard, I think it's about 300,000 people over the course of the life of the SPL who have been deducted over time, some of whom will have been deducted because it was their choice, others will have been deducted because a clinical decision will have been made to say, actually, we don't feel that these patients should be shielding.
Just to add one thing to that as well, that's why we didn't include the shielded patient list people in the risk stratification. We also didn't include people who had had the status changed to being removed. So if someone had been removed from the SPL from a discussion, we then didn't go and process their data again. So we were very cognizant of that clinical discussion always trumped the algorithm.
Yeah.
Right, thank you. And I'm going to ask one more question that Andy's posted in the chat. Algorithms sometimes reflect unknown biases in underlying data. I suppose the question is, what have you or the team at Oxford done to guard against that? To guard against hidden biases in the way we interpret the data.
I mean, there's been a huge amount of work since then. So I think there's QCovid 2 and 3 have been produced since then. So there's a huge learning curve, especially around the data quality and the data quality that we had versus what Oxford had access to. So without going into specifics, yeah, lots of learning and improvements and iterations across all of it. Yeah, but we could give examples, but I don't think we've got time.
That's excellent. Thank you. I'm going to sort of hand over to the third set of presenters. So we've got Rupert, Chaplin, and Efrosini, Setakis. And over to both of you.
Great, thanks very much, John. You're on mute, Efrosini, if you were talking. Sorry.
Sorry.
Rupert Chaplin, I'm head of the data science function at NHS Digital, and yeah, it's not a tag team with Efrosini, who's the principal data scientist and led on the work that we're going to talk about. So I guess it's the nature of these things that each presenter has to talk faster than the one previous. So I'm sorry if it feels a bit rushed. Should we go to the next slide, Efrosini? So the work we're going to, during the pandemic, there have been a kind of range of brand new data sets that have been established out of operational need, largely to both manage the pandemic, but also that we can draw on them to give public insight about the extent and trends in COVID, and this is what this work was focused on. So we were looking at a number of new data collections flowing into NHS Digital and releasing those, and within the official stats framework. So in this work we were in particular focused on the kind of unique view that some of these data sets could give us on the early stage of the pandemic. So particularly where that period before widespread testing was available for the general population. And we were also investigating how we can draw on data linkage and linking records at the person level to both give us a richer picture to kind of enrich our data about. Have we lost slides, or are they coming?
Sorry, I'm not sure what's happening to my sharing. I'm having technical difficulties. I will try again. I'll stop sharing and share again.
I think we have them now, Efrosini, so I think leave it as.
Can you see properly? Sorry, yeah. I can't. Mine is looking weird, so yeah. Okay, if you can see it, I'm happy.
Yeah, that works.
Yeah, we can see it fine.
Okay, yeah. Brilliant. Thank you.
So yes, looking at drawing on data linkage to both kind of enrich our picture of individual patients. So we were able to draw on data from across multiple operational data sets to have a more complete picture of ethnicity and other patient characteristics, for instance. And also looking at data linkage to understand how coverage across different systems and associated with that through coverage through different parts of the care system have changed over the pandemic as well. So three core data sets that we looked at in this work. Firstly, primary care. So NHS Digital has mechanisms for extracting data from GP systems that was drawn on for COVID, this GD-PPR, and the pandemic planning and research data set, which covered patients with an indication of COVID-19. Second data set is level pathways. This is calls into the 111 or 999 service, both over the phone or online, the online 111 service. So here we were capturing calls that ended with a disposition indicating a COVID-19 condition for the patient. And finally, test data sets. So we're looking at, there are several test data sets here, but we're covering all kind of pillars in this work. And as Efrosini will come on to, we're focused in particular around the primary care data set. But first to take sorry, are you on slide 4, Efrosini? I thought I could flick on, but I can't.
Sorry.
Yes, slide 4, please.
Yes.
Great, thank you. So this is looking at, once we had linked this data at patient level, looking at differences in coverage here at different phases of the pandemic. And, you know, this is kind of a reassuring kind of reinforcement of what we would expect to see. So in those first few months of the pandemic, you know, a big volume of patients reporting on COVID or suspected COVID diagnoses through GDPPR, and through their local GP. Also high volume through 111 and 999. You'll recall that early in the pandemic, the 111 service really came to the fore as a kind of primary contact point for potential patients of and SGSS, which is our core testing data set, much smaller there in that early period, but also very little overlap across these three large data sets. So really seeing that by drawing across the three, we build a much more complete picture. On the right hand side here, so later in the pandemic. We see as that kind of testing regime has really kicked up, much closer correspondence between primary care and SGSS, the testing data set, and a kind of shrinking usage of or coverage of patients through 111 and 999. This is during the time when other services are coming more to the fore. I think at that point I'll pass over to Efrosini for a particular kind of view in on the primary care data. Thanks, Efrosini.
Yes, sure. So I will sort of try and whiz through some of the sort of descriptive analysis we did of the primary care data set to get a good understanding of the data quality, and also to get some insights regarding COVID as captured in primary care. And it is available on our website. I've got a link here for anyone who would like to have a more leisurely look at it, and also the graphs are a bit more interactive and easier to see. So we went through we used their primary care data set to sort of filter patients, so capture patients that had either a suspected or a clinical or a test diagnosis as recorded using SNOMED codes. And we were also able to use these data to sort of apply a very definition over time to reflect the different ways that clinicians might be recording COVID in their records, because maybe the codes were not available, or because knowledge sort of increased over time. So in this particular report, we had a cutoff. We had a wider definition for the beginning of the pandemic, where less codes or diagnostic codes were available, and then we made a narrower, more specific definition post 1st of July, which was the advice we received from practicing GPs. The other thing that we were able to do with this data set is actually enhance ethnicity. If you looked at the patient registration data, we only got a captured ethnic group 46% of the data of the patients. If we included SNOMED codes, it would increase to 70%, but we linked to secondary care data, and that increased up to 90%. And we realized that this was a really rich data set that would give us some insight of what patients were getting COVID and their characteristics. Sorry, that doesn't work. So in the study period, which is the 1st of March 2020 to the 31st of March, using our definition, we captured just over 3.2 million patients that had a clinical or a test diagnosis, and over 5.1 million that also might have had a clinical test or a suspected diagnosis, which brings it about 1 in 11 registered patients. But please note that this is restricting to patients in England, as captured in primary care using SNOMED codes. This is restricted to patients that have a valid NHS number, and we kept the analysis on first diagnosis only. We didn't look at multiple infections, but it is something that we could be doing with this data set. So the first thing we wanted to do is to see how did that compare with official numbers, or as reported on coronavirus.gov. So it's quite hard to see, which is why I would suggest if you like to have a look on the report, because those are interactive, and when you hover over, they sort of light up. But the blue line, the bottom blue line in the first wave are the official numbers, which are reflecting the number of positive tests, which we are all aware that they were not widely available at the time. And the grey line on the top is our are diagnosed and suspected, so are clinical tests or suspected, and the darker blue line is just the clinical and test results. And we can see that indeed in the first wave we capture more patients. Of course there is this drop here, but it's artificial because we had that 1st of July cutoff of changing our definition. And then we become more in line with the official numbers, but there is some discrepancy around January onwards, which we believe it's to do with lateral flow tests, because there was no mandate for those to be fed back to primary care, but they are reported in the official counts. So then we wanted to look and understand the type of patients we had, something that we hadn't seen at the time widely available. So we looked at different demographic characteristics. The first thing that was obvious to us, this doesn't work, sorry, is to look at the age distribution. We looked at the time, we decided to look at lifestyle age groups, so like preschool, primary, secondary, university, young people, and going up the scale. For ease, we grouped the over 70s in this graph, and then we looked at them separately. It is quite interesting to see that in the first wave, the over 70s are higher, have a higher infection rate here. This is a crude rate, of course, but this all changes come autumn 2020, where the 18 to 25-year-olds seem to be leading the game, if that's the right way of putting it. The reason I've actually included both of these in this particular setting is what we thought was quite interesting, is that we saw that in the suspected in the primary school age group, we saw a little peak with suspected COVID, which was in September. We are guessing coming back from holiday, going back into school, but this is not reflected with actual tests and clinical diagnosis. And we thought it was quite a nice, interesting thing to see in the data set. Then when we look at the older population, we can see that the over 90s are at higher risk, followed by 80s to 89 and so on. But when we come again into autumn, the younger cohort seems to be increasing first, before the over 90s sort of then peak, and that carries on way into January following vaccination as well, that rollout. And the things we looked at, which we hadn't seen before, were ethnic groups. So we were able to look at the infection by ethnic group. And what we thought, again, throughout this, there is a similar pattern that we see a different story at the beginning, where there's not much differentiation in this visual representation. This is not statistically tested, but then there's a different picture in the second part, where we can see clearly here the Pakistani ethnic group coming up higher, and then the Bangladeshi. Also, the other thing we can see here is constantly the Chinese ethnic group being below, which is not clear from the work we've done if this is a reflection of actual difference in infection rate or behaviours, because we are only capturing who went to their GPs. And this sort of brought to us a thing that we have to be aware of, that we are only seeing who goes to their GP, and it doesn't necessarily mean it's causal or that it's actually real differences. And then the other thing we were able to look at that we hadn't seen done elsewhere was look at social economic status, which we estimated using by proxy, using IMD quintiles on LSOA. And again, we see that in the first part of the pandemic, everyone is about the same. But then come autumn, we can see that the lower the social economic status, you seem to be at a higher risk, which we thought might reflect, public facing jobs versus the ability of being able to work at home. This all changes during the festive season, and then it spreads out again. Sorry, I always like looking at the data and the pictures and trying to work out a story, which is not necessarily the right thing, but it is like the trend, and it looks like the story of the pandemic. Sorry. So in summary, what we believe, having done this analysis, is that primary care is an extremely valuable source of information, especially for the early part of the pandemic. However, you know, it would be good to be using it in combination with other data sets, because as Rupert showed earlier, not one data set captures the whole truth. So it is very important to be able to link to other data sets. We did find that infection rates varied across different patient groups over time. However, this has not been tested. We did not look at interactions, and we know that this is the obvious next thing to do. Also, we know that this might be reflecting infection rates, but it might just be patient behaviours, which again, if we link and we use the other data sets together, we could understand that better. Also, we haven't captured the severity of infection because we haven't looked at patient outcomes at this stage. What we think makes this quite a unique data set is the fact that we are able to vary case definition depending on needs of the question and so on. Also, we are able to look at really rich demographic information, which might not necessarily be available in other data sources. And we are able to put them together as well to get their sort of universal truth, if that exists. And then the most important thing is that what we're looking at, what we are building, is this linked data set that can be used in combination going forward. So I'm going to pass it back to you, Rupert. Sorry.
Thanks, Efrosini. Do you want to click on to the next one? Yeah, so briefly to talk about kind of what we're thinking of next. So I mean, a big challenge in this work was kind of working through data linkage and making sure we've got the right kind of methodologies in place here and assuring that linkage. I mean, it was not emphasised in prior slide, but one characteristic of these new collections is that data coverage can at times be patchy when it comes to capturing personal identifiers, and so real care needs to be taking and kind of linking across data sets and assuring that you are capturing all the linkages that you can and not making false positives. So that's part of the programme for the data science team at the moment, assessing the methods that we use for data linkage. And we are also focused on making sure that we can more routinely and more consistently use these use linked data to tell the story around COVID and more widely. So we spoke a bit about the kind of importance of looking across data sets to get that complete coverage of or more complete coverage of the population. What we're looking at now is also looking at more completeness across that patient journey. So looking beyond primary care to incorporate data covering secondary care, deaths, but also activity around vaccinations, prescriptions, and incorporating the shielded patient list that you just heard a lot about. I think our next slide has got some ideas about the types of research questions that such an asset will enable us and others to tackle. I'm sure people on the call can come up with many other interesting proposals for wider research as well, but I won't run through these in detail in the interest of time. Thanks, John.
Brilliant. Thank you very much. So yeah, we are not a little bit short of time, unfortunately, but I will. I'll just highlight Kieran's comment, which I agree with. That evidence-based storytelling is very powerful, and I think it's very powerful. You know, the information that comes out of this presentation. I just had one sort of follow-up question, which is, so my impression is this is a presentation on what we can do with admin data, which obviously has very wide coverage and potentially gives you good sort of population-wide results. I just wondered how much you'd cross-reference with the more sort of survey-based approach that ONS had taken on prevalence, for example, and whether you sort of looked at how those things relate to each other.
So we have done some comparisons, of course, in order for us to feel that we're happy with our results. We did actually go out and compare, but we haven't done an extensive analysis of the two. But we have compared our findings, and they were in agreement. Some of them, I think, are commented. I think we have commented in the report slightly, but yes, we've definitely done some comparison with the survey data as well. We actually had been in conversation with the ONS group as well, so we have been trying to do this as collaboratively as we can, and to sort of learn from others and sort of share our knowledge as well. So we were also in conversation with them when we were making decisions, and we have been talking through with our results as well. If that answers your question. But
no, it does indeed. Yeah, I think it's just hugely powerful stuff. I'm familiar with some very similar challenges we had on counting how many people have died, which you think would be straightforward, but definitely wasn't.
Yes, I know. It's not, is it?
So I think we're slightly over time, actually. So I think the most important thing to do is to just say thank you. Well, thank you first of all to Rupert and Efrosini for that presentation, to Kieran and Lucy for the middle one, and Sharon for the first one. Three really fascinating presentations, and I think highlights the very, very large amount of work that NHS Digital did during first and second waves of the COVID pandemic. So thank you for the presentation, and thank you also for the work that went into it. Very, very much appreciated. I think that's all we have time for. So I'll just highlight again that for people who attend these sessions regularly, the next session is on the 13th of October, and we'll be addressing the International Day of Risk Reduction. I think that was the official title. So look forward to that one.